തിരിച്ചു വിളിക്കാൻ അത്യാവശ്യമൊന്നുമില്ല. Good evening, everybody. Warm welcome to the ASI Time. This Wednesday, we are going to have a session on how I do it on hernia, and I leave it to Dr. Puneet, Director Academics, ASI India. Thank you, Dr. Puneet.
Good evening, everyone. I welcome you all to the ASI time. That is today, third Wednesday of the month. That is 19th of March 2025. I welcome all the office bearer of ASI, the academic council members, and the dear viewers. Today we are going to have how I do it session in which we are going to discuss about the surgical management of inguinal hernia. We are going to have a video presentation from the eminent speakers today. They are going to show the videos, and this session will be moderated by Dr. Rajiv Sinha, the former professor and head, Maharani Lakshmibai Medical College, Jhansi. So before I proceed with the session, I invite Dr. Praveen Shurvanshi, President ASI, to welcome all the speakers and the moderator and today viewers.
Good evening, everyone. I welcome all the, especially faculties and the online viewers for this very favorite session for all surgeons. That's how I do it. And in that, today we have a very special topic which is very close to every surgeon. Most of the surgeons start their journey with this surgery like hernia, appendix, appendix. I think there are disturbances from someone. So, yeah. So it's everyone's favorite surgery. These are the operations. Initially, we thought it is a GR1, GR2's operations. But now today, with advancement in the techniques and technology, even now hernia surgery itself has become a subspecialty. And it's very important to learn these advanced procedures from the masters and the pioneers in the field. So and we all are very fortunate that we have pioneers in the field, the people who started doing this surgery in India. And not only that, they have taken all great efforts to make it accessible and to make it, available to the every corner of India by the extensive efforts in training and arranging these workshops. So as mentioned by Dr. Puneet, Dr. Rajiv Sinha, who is a very senior professor and pioneer in hernia surgery from Jhansi, he will be moderating this session. Dr. Praveen Bhatia, everyone knows. Dr. Partha Sarthi, Dr. Tushar. So it's really going to be a great session with not only they will showcase their technical skills, but I'm sure they will share their wisdom also, whatever they are gaining throughout this in the last 30 years in doing hernia surgery laparoscopically. So again, I welcome all the viewers and I thanks all the faculties and moderators for accepting our invitation. I also congratulate our academic council member, Dr. Puneet, and all his team member, Dr. Santosh, academic advisor, for taking all these great efforts to make it happen. So thank you so much. I request Dr. Puneet to proceed with the further proceeding.
Thank you, sir. Now I request Dr. Muthu Pandian, the Vice President ASI, for the welcome address.
Good evening, all of you. Really, I should thank the Academic Council for having selected this topic, which is very much useful for the younger surgeons. Of course, I could see the legends in the field of hernia surgery like Sir Dr. Partha Sarthi, Dr. Tushar, and Dr. Praveen Patia. Yeah, often he used to, whenever he goes for a conference, I like his comment on the geographical features around that area, like rivers, mountains, and all. Today, the ultimate aim of hernia surgery is minimizing the morbidity and with the good outcome, preventing the complications like infection and recurrence, everything. Without taking much of your time, I thank all the panelists and the moderator for having accepted our invitation. Thank you, one and all. Thank you, sir.
Thank you. And now I request Dr. Rajiv Sinha, Professor of Surgery and Department of Surgery and the Head, Jhansi Medical College, to proceed with the session. And we have an eminent speaker. First, the moderator is going to introduce the speaker. And after having a video presentation from all the three speakers, we are going to have our question answer sessions. So over to Dr. Rajiv Sinha, sir.
Yeah, good evening, everybody. I think I'm audible.
Yeah, you are very much audible, sir, and you can
Okay.
proceed with it.
Okay, so basically, we are looking at a very small part of the body, namely the inguinal area, which has the distinction of being the most commonly surgically intervened area. But even after 2 centuries, procedures are still being designed. They are evolving. New procedures are coming onto the fore. So if you look at the first inguinal hernia repair, it was way back in 1716. That's almost more than 2.5 centuries back. Demetrius Cantorin. So he did a transabdominal procedure. He did a the first inguinal hernia was a transabdominal procedure. But then the most accepted, of course, in 1880s, we came about 150 years later. 1880s, we had the Bassinese repair. And then in 1982, almost a century later, you had the endoscopic repair starting with Rolf Gehr, then McCrown, and then the TAPP repair. So if you look at the inguinal hernia, as I said earlier, most commonly intervened area of the body, almost 20 million inguinal hernia surgeries done worldwide every year. US accounts for almost 1 million, and India in 2022 figures, if you look at it, is almost 1.18 millions. So this seems to be a very, very appropriate topic, and I think it was very well picked up because this is the most commonly done surgery by the general surgeon, and the budding surgeons, they need to know the technical details of the open hernia surgery and the endoscopic hernia surgery. So we can discuss that later. So without much ado, I think we will go on to Professor Tushar Mishra, who is from All Institute of Medical Sciences, Bhubaneswar. He's there in the Department of Surgery. And I would request him to start his presentation as how he does the open inguinal hernia repair. Over to you, Dr. Tushar. You're not audible. Kindly switch on your mic, Dr. Tushar. Yeah.
Yes, sir. Am I audible, sir?
Yeah, now you're. Yeah.
Yeah. Thank you, sir. Thank you so much, sir. Thanks for the opportunity for delivering this very nice topic, a topic very close to my heart. And as already told by Professor Rajiv Sinha, a topic which is so commonly done worldwide, and it has to be addressed in adequate length to make sure the surgery is safe and correctly done. So today I'll be talking about open inguinal hernia repair. Are the slides visible?
Yes, yes. It's safe.
Yeah. And I'll be stressing upon how I do it. Yeah. So is it important in the laparoscopic era? Annually, 20 million inguinal hernia surgeries are done worldwide, and open inguinal hernia surgeries are the most commonly performed ones. If I talk about this study from Brazil, among the 7,22,680 inguinal hernia surgeries done from 2017 to 2022, 99% were done open and only 0.8 laparoscopically. The figures in India would not be much different. We have evolved from the tissue repairs because of the tension on the suture line, unacceptable recurrence rates, and prolonged postoperative pain. Lichen repair has changed the entire scenario worldwide from 1984 onwards. Using the mesh has decreased the chances of recurrence. The Lichtenstein's repair has certain pearls which are having at least a 7.5 into 15 centimeter footprint shaped mesh, having a 2 centimeter medial overlap at least over the pubic symphysis, a 4 to 5 centimeter above the Hasselbeck's ligament, and a 6 to 7 centimeter lateral overlap beyond the internal inguinal ring so that the mesh ends cross and are sutured to the inguinal ligament. It has to be separately sutured to the rectus sheath and the internal oblique aponeurosis to avoid any damage to the iliohypogastric nerve. The lower edge of the mesh should be sutured to the inguinal ligament with 3 to 4 passes, not more, to ensure that least damage is occurring with non-absorbable sutures. The mesh needs to be kept slightly relaxed to ensure the stress, whatever the patient is undergoing, the transverse fascia accommodates. We need to respect the nerves to decrease the chronic inguinal. So we have to visualize the three nerves, the inguinal, the iliohypogastric, and the genital branch of the genitofemoral. Preserve the nerves along with the facial cover in the natural place. This prevents iatrogenic neural injury, avoids contact of the mesh with the nerves, and we should avoid digital dissection of the spermatic cord to avoid any injury to the deep cremastic fascia, which may lead to perineural injury and exposure of the genital branch of the genitofemoral nerve to the mesh. So the guidelines from the Liechtenstein clinic were clear, but are we following it? The study from Brazil showed that 93% of the cases are being done under spinal, with 53% having the people have their own modifications. Only 70%, a good 30% do not use a standard size and mesh. 25% do not identify the nerves. 50% do not overlap the mesh beyond 2 centimeters of the pubic symphysis. And 55% would not fix it to the, just 55% fix it to the rectus abdominal sheath and the oblique aponeurosis. So how do I do it? In my experience and practice, all the uncomplicated inguinal hernias always undergo surgery under local anesthesia. If a patient is requiring anything more, or the patient is demanding for a laparoscopy surgery, then the patient undergo laparoscopically. Otherwise, all the cases are done under local anesthesia. I'll straight away go to the video. So we use a cocktail of bupivacaine along with a lignocaine with adrenaline. This is the symphysis pubis you are seeing, the pubic tubercle and the anterosuperior iliac spine. We make an incision. This is the groin inguinal ligament. And that is a incision line along the skin crease and the Langan line. The subdermal anesthesia. We start off with the subdermal anesthesia and go on infiltrating. So this patient particularly is not under sedation. And you can see almost the patient will not move in the entire surgery. So once we have infiltrated the subdermal lesion, infiltrating with 2% lignocaine intradermally becomes easy and less painful because the intradermal injection is quite painful for a patient. Now, after the subdermal infiltration, we go for the intradermal infiltration. Infiltrating the xylocaine like this will make the patient pain-free, as well as the field is almost bloodless. We make at least a 5 to 7 centimeter incision as per the patient. This is a short patient and a very small patient. You see, we have just gone beyond the deep inguinal ring. We go on cutting layer-wise. We make sure we use only the cutting current because coagulation current causes little more pain than the cutting one. Before going to the next layer, we make sure we would see the sheath and infiltrate it below the sheath so that by the time we reach the sheath, already the patient is pain-free. We make incision on the sheath, dissect it below the sheath to make sure if the ilioinguinal nerve is adherent to the sheath, then it falls back, and we go on opening it in lines of the aponeurotic fibers. We hold the external opening aponeurosis and dissecting of the underlying muscle. This will ensure the nerve falls down. This is the location where we should be identifying the iliohypogastric nerve and the ilioinguinal nerve. We now infiltrate in the area of the sac. There you are seeing the ilioinguinal nerve. We will make sure that we do not separate the nerve out from the sheath and put it on the mesh. We like to keep it there on the location where it is. That is the iliohypogastric nerve, and this is the ilioinguinal nerve. Both the nerves are well visualized. Earlier, we used to dissect the nerve off. So we have stopped doing that practice, making sure we identify that that's the iliohypogastric nerve. We make sure is we mark the area where the nerve is, and then we make sure we do not take any sutures there. Slowly and steadily, we are taking the cord off the floor at the level of the pubic tubercle. And then we will infiltrate the pubic tubercle because that is one area where still we have not infiltrated and may cause pain. The cremastic box is opened up almost midway, and we try to separate it off the sac, which will soon appear as a white glistening structure, which we have classically read. That is the pearly white glistening structure. We hold it and carefully peel the rest of the structures off the sac. We ensure there's no much of bleeding there because otherwise there will be postoperative hematoma. We are more than comfortable using a cutting current to separate the sac off, making sure we are not staying close to the vas deferens or the spermatic cord. We can use a scissors here, but we avoid much of blunt dissection because we believe that causes more tissue trauma than using done sharply. We may find a lipoma of the cord here if it is available. If it is present, then we should be taking it off. Then we slowly and steadily go towards the superficial inguinal ring as well as the deep inguinal ring. Now here we have separated the sac out. Then it becomes very easy for us to separate the cord structures from the sac using cutting current. Next, we go on to open the sac, see the content, make sure there is no sliding component. Even if there is one, we make sure we do not take a bite through the sliding component and try to take a purslin suture. Some people would believe in twisting the sac, but we believe in doing the suturing under vision. You are seeing the neck of the sac is the narrowest portion, plus we are seeing the yellowish preperiodal fat. There you can see the preperiodal fat. Once you cut it, if it is cut at the proper point and place, then it goes automatically inside. We dissect the sac of the pubic tubercle there so that we have at least a 2 centimeter overlap of the mesh beyond the pubic tubercle. I'd like to draw your attention here towards how we take the bite from the pubic, not from the bone, but from the ligament over it, the corpus ligament. And now you see the suture is taken through the mesh 2 centimeter medial. So that excess mesh is going overlapping beyond the pubic tubercle. That will decrease the chances of a medial recurrence. We need not tighten the suture too much, otherwise the mesh unnecessarily gets crumpled, as you can see here. So I have loosened it further so that by the time you will see I proceed, this crumpling will not be there. From here on, we have to take 3 to 4 or max 5 bold bites on the inguinal ligament, taking care not to prick the deeper structure, that's the femoral vessel, and going continuously beyond the deep inguinal ring. At this point, we have split the mesh to a upper 2/3 and a lower 1/3. And that is the continuous sutures. I'd like to remind you here, we have not separated the nerve out and put it on the mesh. The nerve is lying where it is. And while taking a bite from the inguinal ligament, we have no risk whatsoever. We see the inguinal ligament under vision through the mesh when it is bloodless and go lateral to the deep inguinal ring. The last bite should necessarily include the upper flap also, which we fix it to both the lower flap as well as the groin ligament. There you can see the upper flap going through the lower flap as well as the inguinal ligament. This bite goes through the rectus sheath and comes through the mesh so that the medial fixation of the mesh happens to the rectus sheath. After this, we are left out with 2 bites maximum on the mesh, taking care to remember where the nerve was. So we always make sure to see the nerve through this mesh, or if required, you mark it before and you take the bite. This bite, I have to draw your attention, it is not a tight suture, but a flying knot. So that perchance the nerve has come in between, it doesn't cause pain. And this suture necessarily has to be horizontal, not vertical, because in vertical bite, the chances of encountering the nerve will be higher. In a horizontal bite, it is way too less. Once we are done with that, we just have to close the oblique aponeurosis. We use the same Crowley suture, or sometimes we use a polyglactin suture. Here we are using a polyglactin one. Because we have not taken the nerve out, so we have no risk whatsoever while closing this layer of encountering the nerve or entrapping the nerve in the suture. We make sure that at least one finger tip is passing through the superficial inguinal ring so that there's no ischemic orchitis. We take few bites from the fossa campana and the fossa scarpa to enable us to have less of dead space so that we can do a good subcuticular suturing, which we prefer to do in patients of inguinal hernia. And that is the end of the surgical video. So just to recapitulate, open hernia is still the most commonly performed procedure. Lichen stent is now the gold standard due to its easy reproducibility and cheap and low recurrence rates. Meticulous technique is necessary to prevent any morbidity. Plus, we have to standardize the step and follow those steps every time. Alternate methods like Desardas may be useful when a mesh is contraindicated in emergency scenarios. Thank you. I'm open to any questions.
We are going to have a question answer session in the last. I think we should proceed with
Sure,
this.
sir.
Dr. Rajiv Sinha, sir, you can invite the next speaker.
Dr. Rajiv Sinha, you're muted. Dr. Rajiv Sinha, you're muted.
Yeah, okay. Good evening, Dr. Praveen.
Good evening, sir.
Now I'll invite you to talk about how you do a TEP repair for inguinal hernia.
Sure.
Yeah.
Thank you very much. Yes, sorry. Thank you very much for giving this opportunity to talk to our brethren surgeons all over the country. And I must appreciate the efforts which are being done to spread education. Thank you very much. And today I am going to speak on TEP, how I do it. and I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. I would put it this way, that one has to understand the nuances of myopectineal orifice, whether we are doing TEP or TAPP or ETAP for inguinal hernia. So I have divided my talk into 10 steps. That is essentially, it is a totally extraperitoneal and not extra fascia transversalis repair. Once we are dissecting.
Dr. Bhatia, your slides are not visible. If
slides, yeah. Screen, start, yes. Just a second, yeah. Now, are you able to see that now?
Yeah, it's coming up, yeah.
Yeah, now
okay.
it is.
Sorry for that. So I say that understanding nuances of myopectineal orifice, whether you are doing TAPP, TEP, ETAP. So basic thing is that in inguinal hernia repair, one has to be bothered about that it is called as TEP, totally extraperitoneal and not extra fascia transversalis. Once we are dissecting, then one has to make sure, and it was a beautiful article by Jorge Dias and Edward Felix about the MPO, critical view of MPO. In this, one has to dissect for 2 centimeters into the cave of Resias, so that when we are laying the mesh and when the bladder gets inflated, the up-rolling or under-rolling of the mesh does not occur. Similarly, all of us know that one has to cross the midline, then only the medial most recurrences will be prevented. Follow the white and you are always right. And one has to convert the angle of doom into a triangle of doom, which I will show in the video clippings later on. And one should never ever skeletonize the vas and vessels. One should always peritalize the vas and vessels. We always tell our younger colleagues that when you are doing the hernia repair, please treat it as your own vas so that you do not cause any micro trauma even to the vas or to the vessels. And lipoma, yes, it has to be reduced or excised to prevent the pseudo recurrence. And peritoneum is a single cell thick layer. Again and again, my emphasis would be on that peritoneum is a single cell thick layer and one has to remain extra peritoneal rather than extra fascia transversalis. And when we are laying down the mesh also by 15 by 12 centimeters, then also one should be very, very clear that the inferior margin of the mesh should be lying comfortably and it is not getting rolled up or rolled in. And the superior margin of the mesh should also laterally reach up to 2 centimeters anterior superior to the anterior superior iliac spine. The position of the patient is supine. The surgeon is on the contralateral side where the hernia repair is being done, and anesthetist is on the head end, and both the arms should be tucked along. We do now, for last 2 decades, all the TPs or ETAPs with optical entry. I will show you the video clipping just now. And the trocar positions are also 2 secondary ports are in the midline. Whether we are doing right side, left side, again and again, our thinking is that 3 ports are enough for doing the TEP rather than 4 ports. And then we start systematically from midline to lateral, follow the white, and you're always right. And fat belongs to the anterior abdominal wall. Again and again, one has to make sure that we are dissecting first the direct defect, then the indirect defect, and the chances of seroma should be reduced to the minimum. Mesh rolling has to be done in such a way when we are deploying it, then the inferior and the superior margin of the mesh are comfortably placed. And mesh fixation, we strongly believe on mesh fixation. And again, a small trick I would say is re-insufflation after the mesh deployment. Now in this video clipping, you can see that we are putting in the ports either by OptiView or by the standard previously, which was being done by that we cut onto the anterior rectus sheath. We used to apply the suture onto the sheath and then we go in so that we are able to retract the anterior rectus sheath, and I can show the posterior rectus sheath, and then we go inside with the cannula, and then we are able to see every structure. Now you are able to appreciate that we have gone in and we are insufflating. So this is the way that and the muscle, meaty fibers of the muscle are seen, and two secondary ports are placed from the top to in the midline. And now you can see the position. And again, we always advocate that the lot of barbecuing of the tissues should never ever be done. And in this situation, one can appreciate we are cutting the fascia transversalis with the help of the scissors. One could see the inferior epigastric. So first anatomical landmark was the pubic ramus. Second is the inferior epigastric vessels. And again, follow the white. Are you able to appreciate the pseudo sac of the direct defect? So it goes towards the scrotum, and we are remaining close to the peritoneal sac. Again and again, our intention is loud and clear that we are not going to touch onto the vas and the vessels. We are seeing the psoas muscle here. The nerve, the genitofemoral nerve is present, and we do not want to separate off any neural structures. Again and again, intention is loud and clear that we do not handle the vas and the vessels. And once now you see the 2 centimeters of the area has been cleared into the cave of Retzius. And now again and again, we are sticking close to the single cell thick peritoneum. Vas is seen medially. As the vas is turning medially, then is the limit of our dissection. That was what I wanted to say, was that it is imperative that we convert the angle of doom into a triangle of doom. And again, the triangle of doom would mean that the third limb, the horizontal limb of the triangle, is the reflected portion of the peritoneum. One can appreciate that one could see the obturator now, but one should not make any attempt. And we believe on fixating the mesh every time. And the half of the mesh has been cut, but the suture had been placed. And when we are unrolling the mesh also, make sure that we are unfurling. In TEP, we unfurl it onto the floor, whereas in TAPP, we unfurl onto the top. The aim is that at least 15 by 12 centimeter should be placed in on either side, and the midline should have the overlap also. Again, this is a small video clipping just showing the left side. Whether we are doing on the left side, for example, then I am standing on the right side of the patient. The caressing movements are being done. The tissues are being retracted away. The White House, the lighthouse is being seen. And we are trying to go into the cave of Retzius. Again and again, why I am repeating this, that many times I have seen the surgeons barbecuing the tissues, thinking that ultimately patient will not have pain. In this video clipping, one can appreciate the 2 lamina of fascia transversalis, beautifully seen, and we are cutting with these scissors. Aim is that we should remain pre-peritoneal. Follow the white. First white was the pubic ramus. Second white was, for example, if it was a pseudosac. Third white is a indirect sac. Now one can appreciate the indirect sac which is coming. And again, we remain very close to the indirect sac on both the sides. And here also one can appreciate the pseudosac is being lifted, but we are not using any energy source for that. Just a traction and a counter traction, because if we cause ooze in this small limited field, then the chances of seroma formation will also be there. So we always say small bites, small mistakes. So make sure that if we are using the harmonic or if we are using any energy source, only it has to be judiciously used. Now you can appreciate we have reduced the direct sac. The direct defect has gone in. One can go and do this, the sacoscopy also. And laterally, the superiorly, one has to make sure that we take the incision towards the lateral 2 centimeters anterior superior to the anterior superior iliac spine. And again, the tissues are being caressed for that we are working very close to the white structure, and that is a peritoneum. And once the peritoneum lining, and make sure that we do not cut the peritoneum on the way. That means if we cause any small incision onto the peritoneum, the pneumoperitoneum will occur. Then again, the limited space is there and it will further become limited. So intention is that remain close to the peritoneum but not into the peritoneum. And when we are laying down the mesh also, one should always make sure that we are crossing the midline, we are going into the cave of radius by 2 centimeters, we are covering the defect, the direct defect, indirect defect by 4 to 5 centimeters. One should not cause any injury to the inferior epigastric vessels. Inferior epigastric vessels should always remain clad into the fascia transversalis so that ultimately they are not being injured. Again and again, I am emphasizing here that please do not desiccate the tissues close to the obturator now. And one should be very, very careful when we are working in the close to the triangle of doom that we do not cause. Now one can appreciate even the genitofemoral nerve, the branches of the genitofemoral nerve, the genital branch and the femoral branch. But again and again, we should not unnecessarily cause neuropraxia. And as we make a marsupial, we call this as marsupial, as we go laterally, then we will be placing the mesh in such a manner. Now you see that the external pressure is being done from outside so that one is going up to 2 centimeters anterior superior to the anterior superior iliac spine. One and mid belly of the psoas has to be shown, has to be seen to the camera person also. Are you able to appreciate the mid belly of the psoas? And then the nerves should not be tickled, and then we place in a mesh. Now one can appreciate that this is the genitofemoral nerve dividing into two, the genital branch and the femoral branch. If there is a lipoma in the indirect sac, that has to be excised, that has to be taken towards the peritoneal side so that we do not cause any pseudo recurrence also. Again and again, we place in a mesh and we take a heavyweight polypropylene 90 gram per meter square mesh and make sure that the inferior margin of the mesh is resting absolutely comfortably. The folded portion of the mesh is half and half and 15 centimeters horizontally, 12 to 13 centimeter vertically. And then we open this suture, and after applying only 2 tacks are applied onto the Cooper's ligament so that the mesh does not migrate into the scrotum later on. And then once we deploy the mesh onto the floor, and then we carry on making sure that it is not getting folded in or folded out from any place. And then we check, recheck, cross-check by desufflating the extraperitoneal pneumo and then again insufflate so that we know that our mesh is resting absolutely comfortable. So in this video clipping, again, I would end up by saying that please make sure that we do not have any recurrence later on. Thank you very much. I think I have just left 24 seconds. So I will finish off my video clipping on this and I will invite the questions later at the time of question answer. Thank you very much. Thank you.
Thank you, Dr. Bhatia. Now we'll proceed with Dr. Parthasathi, who would be telling us about how he does a TAPP repair for inguinal hernia repair. Over to you, Dr. Parthasathi.
Thank you, sir. Very good evening to all, and thanks for the opportunity. I thank the entire ASI team and especially for Dr. Sandosh sir and Dr. Puneet and to giving me this opportunity. I'm going to share my slide. So I'm going to talk on how I do it laparoscopic TAPP repair, that is transabdominal pre-peritoneal patch plasty. That is a TAPP hernia repair for a inguinal hernia. Coming to the introduction, inguinal hernia laparoscopic repair became a famous and it's a popular because of the less postoperative pain and quick recovery to the normal activities. The hernia defect is approached in laparoscopic repair is a posterior aspect, and the repair involved the placement of the mesh in the periperitoneal space. All type of hernia repair can be done by laparoscopic TAPP repair, direct, indirect, and irreducible, obstructed, strangulated, any hernia we can go. And the contraindication of is regular general anesthesia contraindication. And I'm going for videos, and the team setup is I do hernia in our hospital gym. We do with general anesthesia, and the patient will be in supine with the head down, little head down, and you can see in the picture the monitor in the foot end of the patient, and the surgeon and camera surgeon stand on the head end of the patient. Coming to the port position, this is a supraumbilical camera port. Sometimes it will go up to the epigastrium if it is a larger hernia, and right and left pararectus working port at the pararectus level on either side of the umbilicus, and it is at the level of umbilical line. That is a working port. Instruments, I start with the Virus needle. That is a closed Virus needle technique. And then 1 10 mm to 5 mm trocars. And always TAPP I do with a 30-degree 10 mm camera. And my left hand port will be the Reddy Carlson blend dissector forceps. And then right hand will be both Maryland and curved scissor. And I use the needle Ethicon needle folder. I don't use any energy device for a TAPP repair. Coming to the technique, peritoneal incision to be made around 3 to 4 centimeter above the level of the upper border of the defect. Then we started doing a medial dissection first, and then I go for a lateral dissection, then dissection of the sac, indirect sac. And if it is a direct sac, I do plication of the sac, and then I fix to the Cooper's ligament, and then I fix the place the mesh, and then I fix the mesh to the Cooper's ligament with the suture 1-0 polypropylene suture. I used to fix the mesh to the Cooper's ligament, and then finally I do the peritoneal flap closer with the 2-0 vicryl. And choice of the mesh, it is a medium size weight mesh, 55 to 80 grams per meter square, and macro porous, more than 1 millimeter size of the porous. And the size of the mesh will be, guideline recommendation is 15 centimeter into 12 centimeter. And usually my patient, I used to keep 17, 12, or some of the cases I used to keep 18 into 12 centimeter length of the mesh. And I fix the mesh to the Cooper's ligament. So this is the video. So that is from supraumbilical view to the inguinal region. And now you can appreciate the camera is in supraumbilical. In case if it's a bilateral hernia, and in case it's a unilateral hernia for a right side, the left hand port will be like this: 2-3 finger breadth below the umbilicus and 2 finger breadth lateral to the umbilicus. And suppose if it is a left side hernia, again 3 finger breadth, 2 finger breadth lateral. So that will be the right hand port. And otherwise, if it is a bilateral, on either side at the level of umbilicus line will be the working port. And I'm standing on the head end of the patient. My camera surgeon is left of me. And that is a bladder, collapsed bladder. I used to catheterize. That is the medial umbilical ligament, and median. Lateral ligament is the inferior epigastric vessel. So about 3 to 4 centimeter above the level of inguinal defect, I started opening the peritoneum. And now you can see I'm started raising the flap. I'm going down. A medial dissection I used to do first. And this is the direct defect. It is a small direct hernia on the right side is being reduced. Once you reduce the direct hernia, immediately we can see the white glistening structure is nothing but the Cooper's ligament. So I'm coming to the lateral side. So that is a transverse facial sling. So all the patient had this transverse facial sling. And if it is an indirect hernia, we have to divide the sling. So now I divide the sling. I'm continuing the medial dissection. That is the glistening structure is the Cooper's ligament. I'm coming laterally. And you can see this lateral dissection. And I preserve the fat plane around the lateral triangle of pain area. So coming to the again medial. So cord structures is being separated and should not hold the vas or should not give any cautery near the vas and the gonadal vessel. So now I'm going down. So now I started doing a paratalization. So I'm planning to keep around minimum 1712 or 1812 Mace. So I have to mobilize the peritoneum. Now this triangle of transverse sling is joined to the spermatic area is seen. So separating the vas and mobilizing at the triangle of doom area. That is the external iliac vessel, artery is there. So you have to come down around 7 to 8 centimeter below the inguinal indirect ring, internal ring. So now you can see. So that is up to that level, almost 7, 8 centimeter I dissected. So this completes the dissection. So now I'm raising the upper flap. So now that is the symphysis pubis. That is the right pubic ramus, and that is the Cooper's ligament. Usually I expose the Cooper's ligament. It is a triangle shaped ligament, and it is nothing but the insertion of iliopubic tract. So that is the vas deferent gonadal vessel. And this is the triangle of doom. Triangle of doom is otherwise called vascular triangle. So all the vessel, important vessel is there. And that is a direct sac, pseudo sac. The direct sac, that is the epigastric vessel, that is the internal ring, that is indirect area. So this is the femoral area. So all the area, direct, indirect, and femoral. So that is called myopectoral orifice of Frouchard. All the potential weak area is exposed nicely, and you can see this one thin layer is covering. That is the visceral component of the post layer of transversalis fascia is covering the vas and gonadal vessel, so that the mesh will not affect the nerve. So that is the triangle of pain, and the fat is covering the triangle of pain. So the direct nerves should not be exposed to the mesh. The perineurium fibrosis will not be there. So that is the triangle of pain and triangle of doom. I'm just showing in the video. So coming to the other side, again the same technique: peritoneal incision, medial dissection, and then lateral dissection is done. So that is the rectus muscle. So I'm keeping 12 into 18 centimeter mesh, polypropylene mesh, and only the lateral border of the mesh will be little curved to accommodate the lateral abdominal wall. And you can see here it's a little bit bulge. That is the pseudosac. I'm going to plicate the pseudosac. For that, I take the needle into the Cooper's ligament, and then I take inverting the pseudosac, and then I'm taking a bursting stitch using the 1-0 polypropylene suture, that is a proline suture, and then it is like a bursting after inverting the pseudosac around 1.5 centimeter from the edge. So this is the gem technique of plicating the pseudosac, and this will avoid the bulging, and then the mesh contact to the direct area is there, and then chance of recurrence is less. Post of seroma is almost nil. Now you can appreciate here there is no bulge externally. So the patient satisfaction rate is high after this plication of pseudosac. So the mesh is kept. And then this is another mesh on the right side. It is 18 into 12 centimeter mesh. So all the potential area, myopectoral orifice of Frouchard is well covered. Above and below is around 6 centimeter. On either side, medial and lateral will be around 8 centimeter. It is covering. And my preference is Cooper stitch and 1-0 proline I'm using. You can see it is very strong. And I'm taking only Cooper's. It is not a periosteum. And if a periosteum means you will feel a struggle and your needle will bend, you feel struggle. Now you can see it is very smoothly I'm taking. So that is a Cooper's ligament. So only 2 suture I used to make it even in a direct or indirect hernia, only on the Cooper's. I don't make it in any other places. If it is a very complex hernia, then if I keep a drain in the scrotum, then I used to make another stitch on the lateral conjoint portion of the abdominal wall. Otherwise, Cooper stitch is the only stitch for a mesh fixation. And I used to close the peritoneum in a continuous fashion like this with a 2-0 Vicryl. You can use a 2-0 PDS also. And after 2-3 suture, I used to lock. You can see I'm just locking the suture And when I tightening it, you can see my left hand is pulling the peritoneum up towards the upper flap. So that's why the peritoneal tear will not be there. Left hand is pulled, say like this, so that the peritoneal will not get teared. So completely it has to be closed in a continuous manner. I don't use taker. No surgeon in gym using a taker, or not even one case we use, and suturing is our preference. So it is completely, the peritoneum is being sutured. Any rent is there and you can make it suture after that. So after that, the omentum will be placed and the surgery is over. So this is the way we do TAPP. And you can see that is a simple case. And this is one of the tough case, that is a sliding hiatus, inguinal hernia. And you can appreciate here, it's a sigmoid colon is going inside, and it is a irreducibility. Clinically, it is a irreducible hernia. Even under anesthesia is not able to reduce by external pressure. So it is combination of external pressure and the internal, no, I'm taking down. I could able to reduce this content partially. I'm not able to reduce completely. So I made an extra trocar in this case in a right subcostal area. The extra trocar, I'm holding the peritoneum, lower flap, and then I'm using two hands to reduce the content. So now I'm reducing the content from the pseudo sac. This case is a direct sac, direct hernia, long-standing direct hernia. We will have a sac, even though it is called pseudo sac. We will have a sac in a true peritoneal sac in a long-standing direct hernia. I'm reducing the content, all the adhesion is being released. So this is a big direct hernia defect is here. So now I'm dissecting laterally from the cord structures. I'm taking the transverse sling, transversalis facial sling, triangle of doom is dissected. So after dissecting completely, then I can keep a mesh. So now that is the entire content is dissected. And this patient had a other side hernia also, small direct hernia, that also I'm doing it. So it is a basically bilateral TAPP. Now you can appreciate this is the extra port I made on the right subcostal area. Now you can appreciate the external view. It's a very huge posterior defect, very large hernia. The entire posterior floor is got weakened. So again, the same technique, I'm taking a Cooper's ligament in a reverse way, and then I invert the sac by external compression, and then I'm taking a bursting stitch. It's around 1.5 to 2 centimeters from the edge of the sac, so that the puckering will not be there. If we take at the edge, it will make a puckering. And then when I'm taking on the posterior floor, and I must very careful, I just take only the sac. I'm not including the vas or something, because if we're not inverting, then it will be injured the vas. That's why you have to invert the sac, and then we have to take it. Now again, I'm taking the Cooper's ligament. So it is a 2 times Cooper's ligament is taken. It's a unidirectional stitch. So now you can see the externally, it is totally collapsed. The 14 millimeter pressure, there is no bulge. So that is the advantage of this plication. And again, 12 into 18 centimeter polypropylene macroporous mesh fixation to the Cooper's ligament. So it is very strong. So only one suture I'm going to fix. So again 17 into 12 centimeter or 18 into 12 centimeter, and then peritoneal closure. Even in a large sliding hernia, the TAPP we can do very safely without any injury to the structure. And this is the last video. And again, indirect sac. This is the indirect sac with the obstruction. Clinically, a large, you can appreciate large small bowel. Almost a part of the small bowel is inside. And I'm taking the camera inside. This is a large inguinoscrotal hernia. Basically, most of the surgeon, they lift the sac. They don't take the sac. This video, I'm going to show only the sac dissection. And my practice here in our gym, practice is we used to take the sac completely without any injury to the cord structure. We don't follow this abandoned sac technique. And for that, we have to divide the transverse facial sling. That is, the sling is one holding the sac in the anterior, medial, and part of the posteriorly. And I'm just pushing the, dividing the transverse facial sling. And then I'm taking the transversalis fascia from this sac. Then these type of large sac, I used to keep extra port, and then that port will hold the sac so that I can use two hands to mobilize the sac. Now you can appreciate the complete sac is being taken down, and without any bleeding. And I'm going very close to the sac. Now the vas is getting separated. Gonadal vessel, we can able to see and then we can separate. And because the sac is held with a separate instrument, I have a two hand to work. Right hand is Maryland, left hand is the Reddy Carlson clamp. I'm using only monopolar. I'm not using any. Now you can see I'm taking the camera. There is no bleeding in the scrotal area and the entire sac is being taken out. And here I'm doing a defect closure, that is a iliopubic tract repair between the conjoint tendon and iliopubic tract after placing the drain, so that the seroma will not be there. Again, 18 into 12 centimeter mesh is being placed. All the potential area is being covered. And then I'm doing a peritoneal closure. So now you can appreciate the thick sac, a big sac is being taken down, and this is the way we do. Sir, is the time is over, or can I show femoral hernia video, sir?
I think we should stick to time, sir.
Okay, sir. Okay. So with this, I'll finish, and we have a 10 reason to finish do the tap, and these are all the 10 reason. And tap is an excellent exercise to learn and practice laparoscopy, and it is easy to learn and easy to teach others. Thank you so much, and you can watch my channel of laparoscopy. It's a YouTube channel. All my videos will be there. Thanks for the opportunity, sir. Thank you so much.
Thank you, Dr. Parth Sathi. Now I think, Dr. Puneet, we can take up the questions now.
You can go ahead with the questions.
Yeah. Okay. So first, we proceed in the order in which the talks were positioned. So there are some questions for Dr. Tushar. So one is there any role for excising a thick cremaster?
So as far as possible, the cremastic muscles have to be preserved. Otherwise, we are likely to increase the chances of an injury to the genital branch of the genitofemoral nerve. So we better not do it. We can just mobilize the sac, and that's it. We should dissect the sac off and leave the cremaster where it is.
Okay. And why perform hernia surgery under local anesthesia when regional is absolutely comfortable? That's the second question put in by one of the viewers.
So I have just the reverse question. Why perform under regional anesthesia when local anesthesia is absolutely comfortable?
The point well taken, I think. But one thing which I would like to point out, and also we mentioned in one of the questions, is that in a routine inguinal block, you were not doing the anesthesia, giving the local anesthesia like is done in a routine inguinal block. There is a injection at the just medial to the ASIS, and from pubic tubercle right up to the umbilicus on the medial side, and then at the mid inguinal point. So any reason why you didn't follow that routine? That's also one of the questions which I will put in.
Sir, we have done a study, randomized control trial on this in 2014, where we have done 50 cases in each arm. We have done something called a T-mission anesthesia, the technique which I just showed. Using the T-mission anesthesia, you go on the field block, and this is the more recent and the better technique, where you're using less of anesthesia, and the chances of having pain is much lesser than in a field block. The field block, if you're not actually going to the right level and infiltrating the right place, the anesthesia is not as well. You have to add on to give local field blocks again, local on-the-go blocks again. So while doing a T-mission anesthesia, it is so very comfortable to go as you are cutting a particular layer, that the chances of pain is less, and the chances of giving having the dose of anesthesia is much lesser. We use diluted anesthesia. We do not use the complete concentrated 2% anesthesia. We hardly use a 0.25 to 0.5% anesthesia.
Okay, and one other question put in is, I think that is routine sliding hernia management in an open. I don't think that is much to say. I think what do you do when you have a sliding hernia?
So I've just covered that in my video, sir. So if there is a sliding hernia, what we do is we go beyond the sliding hernia and we try to just invert the sac beyond the hernia and push it down. If the sac is too large, we can just take two placating sutures so that sac doesn't come back again, and we fix the mesh where it is.
Okay, now I'd like to put in a question, and that is, now when we talk about open inguinal hernia repairs, We are basically talking about the open anterior repair, and we are also talking about the open preperitoneal repair.
Correct.
What we now know as a TIPP or
Yes, sir.
modified APP, as we started doing it in 1995. We've been doing it since that point of time. And even in the editorials and review articles, one was John Morrison in 2018. So he stressed that if you have to do open hernia, you should be well versed in number one, herniorrhaphy. You should be well versed second, open anterior repair, and number two, open preperitoneal repair. So what's your take on that? And have you
Sir,
done TIPPs?
yes, we have done TIPP, sir. So TIPP is a doable procedure if you're going to the right plane and pushing the mesh into the right place. It's almost like doing open TAPP, but the mesh size would not be as large as what it would be. So possibly my take on the TIPP is we may not be covering the hernia. If I'm going for a TIPP, rather I'll go for a and in TIPP I have not done under local anesthesia. So for me, it is much more comfortable to because I'm going much closer to the peritoneum. So in a TIPP, if I'm doing on a regional block, then possibly yes. If I'm doing a local, I will still go anterior. Again, if I'm going by regional, I'd rather go for laparoscopic repair. I'd rather go for TEP rather than doing a TIPP. So that's my take on it, sir.
So
I
basically,
work in a
yes,
government institute, sir, where we have lot many cases lined up. So if I have to finish up cases, I'd rather do in the local OT than trying to do in a general.
no, but that is an extraneous reason for that. So basically, we can't go by that anyway. But I think TIPP is a doable procedure. The only problem with doing an open preperitoneal repair is that standardization of this procedure and replicating it is slightly difficult for the simple reason that here you are looking at your tactile sensation. Is the
Correct.
finger which is causing the dissection, and everything is not visible as in a laparoscopic repair. But yes, a TIPP is a repair which is now coming a big way all across Europe. They're doing a lot of TIPPs. So I think that is a procedure that which can be propagated to the younger surgeons also. Right now, I think coming on to Dr. Praveen.
Sure, sir.
One question: have you done a TEP under local anesthesia?
Never.
And what's your take on that?
I
There are
would
a
never.
number of papers now on TEP and local anesthesia.
I would never ever do it. I have never done it. And our thinking is that ultimately it is the pain factor which is very, very important. Can you imagine, Dr. Sinha? I did thesis way back in 88 on shoulders repair under local anesthesia. And we had done 250 odd cases and we called them. It was an excellent method, but the method which you are mentioning, that total inguinal block was given rather than infiltrating only at the skin. So our thinking is that if the patient is having recurrent hernia, if the nerves have already been cut, then local anesthesia will not be at all useful. And the TEP or TAPP has to be done under general anesthesia, not even regional anesthesia.
So okay, so these papers which come, and even the SAGES has come up with the suggestion that it can be done under local anesthesia. I was going through the SAGES recommendation. So questions for you, which is specifically for you, that hernia is an advanced lab procedure by classification. So when should you advise a resident to start looking at a lab hernia repair?
Once he has done good number of open inguinal hernia repair, Lichtenstein repair, once he has seen the other senior surgeons, maybe 50 TAPPs, 50 TEPs, and then he has assisted and he's being proctored by the surgeon, senior surgeon, then only he should be able to understand the anatomy well and then do the TEP or TAPP. But the dictum is that learning anatomy is easier in TAPP rather than in TEP.
I would tend to agree with what you're saying. About, I think, 15, 20 years back, it was said that at least 100 procedures are required before you go ahead and start doing a laparoscopic hernia repair individually. But now, with the propagation of laparoscopy, which is there in every medical college, and by the time the patient comes to a hernia, is already very versed in handling those instruments, doing lap cholecystectomy and things like that. So, handling of the instrument is a very major factor. Once the resident is very comfortable with these instruments, so that has brought down the learning curve to almost 30 to 50. And as you rightly said, that assistance is very important, assisting a mentor or a mentor assisting you. Both the things are very important. Only then if should go ahead and go in for a laparoscopic inguinal repair. Another question for you is
Just a sec, sir.
that
Dr. Sinha, I would add on that knowing thy anatomy well is a
no,
prerequisite.
absolutely. That no surgery without anatomy is no surgery.
No surgery.
It is basically a
Inguinal hernia
technician who is
surgery.
doing it.
I know.
If you're a surgeon, you have to know your anatomy.
Know your
I
anatomy.
tell my residents that there's no difference between you and a technician if you don't know your anatomy. It's as simple as that.
Absolutely.
So, second question is fixation of mesh mandatory in TP.
I would say yes, the literature also supports that fixation has to be done. And we have had the anecdotal experiences of tackling other surgeons' TEP recurrences once the patient had come with the mesh in the scrotum. And then I phoned the surgeon and he said that, yes, I do not fix the mesh at all. But our thinking is that 2-point fixation on Cooper's ligament are enough so that, and the large size mesh, as Partha Sarthi was also mentioning about that 17 by 12 rather than 10 by 12 size. So bigger size mesh and fixation has to be done either with suture or with the tacker so that we do not have the mesh in the scrotum.
Yes, so I would tend to agree with that. In large hernias, it's always better to fix the mesh with 1 or 2 tackers. In very small hernias, there is a case for not putting in any tackers. But in a larger hernia, what are your tips to avoid a seroma?
And as I mentioned, that if it is a direct hernia, then we definitely, as Dr. Partha was also showing, that we fix the pseudo sac to the Cooper's ligament with the tacker only, and then place in a mesh. And if it is a large indirect hernia, then we take the lateral most portion of the indirect peritoneal sac and fix it to the anterior abdominal wall with the help of maybe V-lock suture, so that the ultimate seroma formation is definitely decreased.
Okay, one question from my side. Have you put in a drain in the preperitoneal space after doing a TEP?
Yes, only one case in last so many 4 decades. Why? Because it was a large inguinoscrotal hernia, and I was bothered about, and I left the drain into the scrotum rather than into the preperitoneal area, just to be sure that it does not lead on to huge collection or seroma later on into the scrotum. One case only.
Okay. And when would you advise not doing a TEP and going in for a TAPP? In which scenario?
Excellent. For example, if the patient has a recurrent hernia, and if the patient has post-open recurrent hernia, if the patient has post-TEP recurrent hernia, then definitely TAPP is better proposition. If the patient is definitely morbidly obese, maybe 40, 45 BMI, then also find out the space in TEP becomes challenging. So it is a good idea to go in for TAPP. And we do not combine with lap poly with the hernia repair. But for example, if the patient has hiatus hernia and the inguinal hernia or umbilical hernia with the inguinal hernia, then we definitely place in by TAPP method rather than TEP method.
One more indication I'd like to add on, and the recent recommendation 2023 recommendation that now laparoscopic hernia is a distinct possibility, even in emergency inguinal hernias. So if you're doing emergency inguinal hernia, what is advised is you have to perforce go in for a diagnostic laparoscopy.
Sure.
So if you're doing a diagnostic laparoscopy, you may as well convert into a TAPP rather than closing it and then going into a TEP. It doesn't make sense at all.
Absolutely.
So with the advent of these guidelines that you can, even with an obstructed hernia, you can go ahead and put in a mesh, doesn't create a problem. So latest 2023 guideline.
Sure.
Okay, so basically, are you routinely doing it in emergency as a emergency hernia presentations?
Yes, definitely. But as you have rightly mentioned, that we have a very, very low threshold of doing the diagnostic laparoscopy. As soon as the patient comes and the patient is induced, we try to reduce the hernia on the table. And if we are able to reduce it, then we go in for TEP. But if we are not able to reduce it, if it is irreducible, if it is obstructed, then we place in the scope at the palmer's point, see from within. And if we are able to still do it, yes, TAPP is good enough. Otherwise, we convert and do the open surgery.
Yeah, because one thing which is important that the collection in the sac does not create more of a problem even with the polypropylene mesh put in a TAPP repair as it was believed to be causative in the early stages. So that is the new recommendation. Okay, coming to Dr. Parthasathi, there are some questions for you. What is the most important advantage over TEP as far as the TAPP is concerned?
Sir, it is as you told now, it's a diagnostic laparoscopy is possible. When you go in, we can see the entire abdominal cavity, and then we can see the contralateral side. That is the second advantage. Third one is we can straight away on the inguinal region. All the anatomy is so clear. And in TEP, we have to dissect and then we can reach the inguinal region. Here it is straight away. We can see all the anatomical structure, hernia, other side hernia, and then we can start the procedure.
And
So
then a perennial burning question, open for discussion everywhere. A TAPP and a lap chole at the same sitting. What's your take on that?
So
In
usually we
every
don't.
conference, you'll have this question keep popping up, especially even
Yes,
with
sir.
ventral hernia.
Yes, sir.
Lap chole and ventral hernia,
The
lap chole,
TEP,
inguinal hernia. Your take on that?
the TEP with lap chole, it's very well acceptable, sir. We are doing regularly. But
Okay.
TEP, even if you close this continuously with the peritoneum, some peritoneal fluid can go inside. So that's why if you combine other procedure, other abdominal procedure, TEP is better than TAP.
Which would you do first, the chole or the hernia?
Hernia first, then chole, sir.
Then the chole, because you want to wall the mesh off. Is
Yes,
that
sir.
the reason?
Yes, sir. First hernia, then we can go for lap chole.
Okay. What's your experience on a single peritoneal window for bilateral inguinal hernias in a TAPP? Have
Sir,
you done
even
a single
if,
peritoneal window?
yes, sir. Even if it is a single peritoneal window, the inguinal region is little obliquely placed region, sir. So we cannot keep a large single mace. So even if it is single space, we have to keep a two mace. So some barrier is in between. So the peritoneal closure is easier. So that is the
Yeah,
main.
so no, the single window, what I'm meaning is we are not going through the midline. We are not transecting the area of the urachus or the median or the medial
Umbilical
umbilical
ligament.
ligament. You are proceeding laterally. From there, you can go ahead. And this becomes more easy if you're doing a single incision TAPP, because there the movement of your instrument becomes much easier because they've got a very small fulcrum as opposed to a routine TAPP where the fulcrum is broader because you have both the ports at the semilunar line. So it becomes more easier with a single peritoneal window. Now, one thing I saw was that what has now been recommended is that in a very large hernial sac, it's a scrotal hernia, we tend to transect the sac rather than trying to drag everything back because the incidence seroma becomes very higher in those cases. And I saw that you were trying to, or you routinely bring the whole sac back. So,
Yes.
any reason for that?
Sir, almost near native anatomy, we are creating it. And so most of the time, most of the patient that comes with sac, it's easy to take it off, sir, because it's a 4K view. And if you go in a plane, so it is once two places the sac is holding, one is a transverse facial sling just below the internal ring. And then once you cross the internal ring, the cremastic fascia. Once you tackle this, the sac will come out easily. So everybody's why they're leaving a sac is because of cord structure injury. Without injury, we can reduce the sac. So that is the belief that no, we can most of the cases, almost all cases, we can able to reduce the
So,
sac.
as opposed to transecting a large sac, you would still advocate bringing the whole
Seroma
sac back
formation is
into
high, sir.
repositing it back.
Yes.
Okay. And just one for the laparoscopic, the importance of the Bogros space. This is one of the questions which is out here.
The space of Bogras, otherwise called lateral space. So all the nerves are there. It's called triangle of pain areas, or otherwise called trapezoid of Diaster. And so all the nerves are there. So we have to keep the fat covering on the lateral Bogras area. And then any suture, clipping, taker, or applying cartridge should be avoided on the triangle of pain area. That is a Bogras area. So below
I'll
the
just like to put in a word. Dr. Bhatia, would you like to put in any word on the Bogros space?
Yeah,
Or
definitely.
you agree?
No, I would agree, and we should not at all touch the nerves in order to not to have the neuropraxia. We should all the fat belongs to the anterior abdominal wall, so let it remain there. We should remain pre-peritoneal, and the Bogro space has to be created in such a manner. Then marsupial has to be created in such a manner that even the large size mesh of 16 by 12 or 16, 17 by 12 is resting absolutely comfortable without any turns and tilts. So that is the basic philosophy, and one should make sure that we are seeing the mid valley of the psoas, and we are seeing the iliacus also, and we are not at all touching the nerves.
Okay, so I just like to put in a word out here, and it's very important that we stop when we talk about the Bogrov space. The Bogrov space is two kinds: anatomical Bogros and the surgical Bogros or the laparoscopic Bogros as we know it. The anatomical Bogros space is a very, very small space, 1.5 centimeters into 0.8 centimeters. Imagine, there's a very, very small space, and it's directly overlying the junction of the external iliac vessels and the external iliac artery. This was basically designed as a space for the approach to these great vessels. But later on, when laparoscopy came up, this Bogrov space, the term was more loosely used, and now everything which is lying lateral to the lateral inguinal ligament is considered to be Bogrov space. So now what we know as a Bogrov space is not the original anatomical Bogrov space. This is what we, laparoscope is called the Bogrov space, everything lateral to that, right up to the ASIS, so that you can dissect there and prevent injury to the nerves and so on and so forth. So Dr. Puneet, have I missed any questions? I think I've taken up most of the questions. If
I
there's
think we
any,
have
then
covered
I
most of
think we
the
can.
questions which are there on the YouTube, sir.
Okay, so I think it
Dr.
was a
Sinha,
very, yeah,
just a small word, if I am allowed to say. But
yeah.
we do not believe on combining the lab chole and the hernia repair.
Yeah, I was looking at your this thing, and so I
Our
think that
our
that is
thinking
that
is
is
that
open for debate.
even
That
one
is
mesh
open
is
for debate.
better.
I think we'll not debate that here.
Sure.
We leave that for one of the open discussion, one of the conferences.
Yeah.
So I think Dr. John and Dr. Puneet, I think if there are no more questions, I think if we can wind up this session. It was a very nice presentation as how I do it by Dr. Tushar, by Dr. Padasati, Dr. Bhatia. And I think especially the budding surgeons and the residents much have benefited from these important steps. And then I think the questions also were which were put forward by the audience. They were very pointed questions, and that also should be helpful to the audience in general. So I would say thank you to Dr. Puneet and Dr. John, and to the whole ASI office official body for giving me the opportunity to moderate this session out here on inguinal hernia repair. Thank you.
I think before we end the session here, we ask any of the ASI office bearer to put any questions there to the speakers or to the moderator.
Good evening, sir.
Yeah, Dr. Sasmal, you can go ahead.
Extremely nice presentation today, actually really enlightening. And all the speakers did a very nice job by putting on the recent, all the versions regarding the indications, contraindications. One short question and short answer I expect from Bhatia sir. Sir, what is the indication of going in for an open hernia surgery in the present world by you especially, leaving aside the recurrent after a laparoscopic one?
No, as we mentioned also that, for example, if a patient has presented with obstructed or query strangulated inguinal hernia, definitely I will do the diagnostic laparoscopy. And if I am not able to reduce it, then, and if there is definitely a doubtful, then I would go in for open hernia repair rather than persisting on with.
No complications, sir. Only primary, incomplete, uncomplicated, unilateral inguinal hernia.
Yeah. If it, for example, if it is a large giant inguinoscrotal hernia, also still we will go with ETAP, still we will go with TAPP, but open surgery, no. And but on, can you imagine, day before yesterday only, I did open hernia Lichtenstein repair for one patient of 92 years old, and he presented with obstruction. He was on clopidogrel. We could reduce the content, but again, our anesthetist was also comfortable that if you do the Lichtenstein repair, good enough. Good enough. Rather
right
than
answer, sir. All the hernia surgeons should be well versed with both open as well as laparoscopy. Thank you.
Absolutely, absolutely.
Just one word for Dr. Saswal, and that is that even with all these indications for going in for laparoscopic hernia repair, the permeation of laparoscopy is a very, very woefully almost 20%, even less than that. The highest that you find laparoscopic hernia being, I'm talking about inguinal hernia repairs, is almost 50 to 60% only in Netherlands and in New Zealand, I think. Europe, certain centers, yes. But in other centers in Europe, it's less than 5%. And US, imagine, less than 20%. So it is still not permeated down to the grassroots level. So one of the, and it's not only the expertise involved, there are a number of factors which has led to the decreased permeation. So that brings us a very important question that in the foreseeable future, what do you think is the future of a laparoscopic inguinal hernia repair and a robotic inguinal hernia repair?
Sir, if I may tell that in
I think we
US,
should wind up here, sir. We are
sure,
running short of time. So we have
Okay,
overshadowed
Shelly, so
our
we'll
time.
leave
So I
that.
thanks everyone. We have a wonderful discussion. And you have already pointed out, it's a complex surgery. It's not a simple laparoscopic surgery. So inguinal hernia is mostly been tried by the surgeon who is well trained there in the open surgeries and very well versed with the anatomy of the inguinal region, must have seen good number of cases before one should venture into the laparoscopic inguinal hernia repair. Now I request Dr. Gadi Divakar to give his comment.
Thank you, Dr. Puneet. Good evening, everyone. So on a lighter note, in a postgraduate examination, if a postgraduate used to get a hernia case, then it's supposed to be a 100% failure for him. And with so many advancements in surgical techniques of hernia, the passing of postgraduate is going to become much more difficult. I know that. And today's discussion of hernia surgery has definitely provided valuable insights into the latest advancements of how to manage that. And comprehensive surgical techniques and these techniques will definitely contribute to the better patient outcomes with enhanced understanding of the techniques. And I extend my sincere gratitude to all the speakers for their expertise. And let us continue to apply these learnings in our clinical practice, ensuring the patient safety and more effective care for our patients. Thank you.
thank you.
Now I request Dr. Santosh John Abraham to give his final comment.
Nothing, sir. It's almost exhausted, except for the fact that I would have been very happy if Dr. Rajeev Sinha mentioned about his favorite, the ligament, which comes on the medial aspect. I have taken a lot of clues from you. Anyway, that's beyond the point. Thank you.
Dr. Rajeev Sinha, you want to comment anything?
No, I've already commented. Thanks to everybody, to the audience, thanks to the office bearer, thanks to you, thanks to Dr. John, and of course, thanks to the to
I,
the to the
I think
speakers today.
I request Dr. Madhumita to propose a vote of thanks. She is a honorary treasurer of ASI.
Thank you, Dr. Puneet. At the outset, I thank our president, Dr. Praveen Suravanshi, for encouraging all these academic events. I thank our immediate past president, Dr. Prabal Nyugi, and our vice president, Dr. Maruti Pandian, for their valuable inputs. I thank our academic advisor, Dr. Santosh, our academic director, Dr. Puneet, and all the members of the academic council for bringing out the best of everything in these academic events. Thank you, Dr. Rajiv Sinha, for a very nice moderation. It is very interesting to know that the first hernia repair was actually transabdominal. And we have again back to our open and a transabdominal area. Thanks to our presenters for their excellent presentations. Thank you, Dr. Tushar Mishra, Dr. Praveen Bhatia, and Dr. Parthasarthi. At last, I thank our secretary, last but not the least, Dr. Dibakar, for working hard behind each and every program of ASI. And my thanks to all of yours along with ASI.
Thank you very much, Dr. Santosh. Excellent job.
I thanks the moderator, Dr. Rajiv Sinha, speakers for today's session, Dr. Tushar, Dr. Praveen Bhatia, and Dr. Parsarthi, and all office bearer and the viewers for attending this session. Thank you. Here we end our program.